Hello everyone, I'm Manor Magdi Ahmed, fourth year medical student at LSU University and MCS Vice Chair at MCOG. And here Dr. Yasmin Ismail, resident doctor at Family Medicine Department at LSU University and Vice Chair of Practice Office. Today we will going to talk about rule of prediction model in management of trial of labor after cesarean section. As we all know that the rate of cesarean delivery has been rising up worldwide. According to ACOG and American Academy of Family Physicians, which states that there is 1 in every 3 persons in the United States are delivered via cesarean delivery. So what can cause this dramatic rise in cesarean delivery? Actually, this dramatic rise in cesarean delivery may attribute to several emergent factors, such as regression number of vaginal delivery and vaginal breach. One of these factors is women who undergo one previous cesarean delivery before. Actually, those women have like 50% chance of repeat cesarean delivery in the next pregnancy. Therefore, to lack or trial of labor after cesarean delivery is considered as the most practical approaches to control cesarean delivery rate. TULAC is associated with risk factors. One of these risk factors is risk of intrapartum cesarean delivery. And we should to take into our consideration that the risk of intrapartum cesarean delivery are associated with higher preoperative complication compared to planned repeat cesarean delivery. TULAC is also associated with risk of uterine rupture. So, the development of this guideline was first beginning by defining clinical question. Then we conducted literature search on the most recent guideline. The second step was to divide the topic into 2 specific linked questions. Each one was assigned to a panel of 2 researchers. These panel commenced reviewing this question and how these guidelines addressed this question. Then we conduct a systematic review of literature to retrieve relevant studies, including systematic review. And the 4th step was to survey obstetricians based in Middle East to assess their current practice against standard practice. TULAC is affected by several factors that has been recognized in the literature, such as previous successful VPAC, indication of previous cesarean delivery, maternal and fetal weight, need for induction of labor. Therefore, assessment of individual risk will permit us improve decision making, and that's what our guidelines aim to. It aims at raising evidence beyond application of prediction model in women considering management of women considering TULAC. We review all the literature that talk about factors affecting TULAC, and one of the most important factors and previous vaginal birth in prospective multi-center study, which reported that there is a direct proportion between number of prior vaginal delivery and the success rate of VPAC. And another one of the most important factors is maternal comorbidities. A retrospective study of 76,000 women showed no association between VPAC rate and gestational or pre-gestational hypertension or diabetes. And our MCOG summary of the recommendation, we recommended that intra-pregnancy weight change may affect probability of success of vaginal birth after cesarean delivery with level of evidence 2B and grade of recommendation B. A previous vaginal delivery significantly increased probability of vaginal birth after cesarean with level of evidence 2B and grade of recommendation B. Evidence on impact of gestational age on the probability of vaginal birth after cesarean is controversial with level of evidence 2B and grade of recommendation B. Induction of labor is associated with lower incidence of successful of vaginal birth after cesarean compared to spontaneous labor with level of evidence 2A and grade of recommendation B. So what about success rate of VPAC and risk of VPAC?
This is a very important point. When a physician counseling a female about TULAC, she will ask important questions. Is it safe for me? What are the risks? What is the success rate for me, for my case? TULAC is overall considered a safe option in most women after one previous cesarean delivery. However, they are prone to a variably increased risk of emergent cesarean delivery, maternal hemorrhage, and uterine rupture compared to the baseline. TULAC is associated with a higher likelihood of emergent cesarean delivery compared to planned cesarean delivery. Emergent cesarean delivery should be introduced to a woman in the counseling as a possible complication of TULAC. This is our recommendation about safety and risks of TULAC. Induction of or augmentation of labor compared to the spontaneous labor increase the risk of uterine rupture. The short interval between two pregnancies increase the risk of uterine rupture by 2 to 3 times compared to the baseline, especially when the interval is less than 6 to 18 months. Risk of uterine rupture doesn't increase in women between multifetal gestation compared to the singleton pregnancy. The sonographic measurements of lower uterine segment thickness may be considered a negative predictive test of uterine rupture risk. The measurement greater than 3.6 has a lower likelihood of uterine rupture. The emergency cesarean delivery is associated with a higher risk of maternal and fetal complication, as fever, uterine tract infection, wound descent, DIC, and return to the theater. This factor should be discussed with the patient in the counseling. Finally, vaginal birth after cesarean practice should nationally endorsed in the national guidelines. VBAC prediction models. Why we need prediction models? As there are several demographic, medical, and obstetric factors may impact the clinical outcome and the probability of TULAC success. So we need development of prediction model to accommodate all the factors and quantify overall the risk. The purpose of prediction models have been to facilitate patient counseling, monitor risk outcome correlation, and in many instances to recommend or advise against TULAC. Group Man's normogram, this is a prediction model introduced in 2007, is one of the most known models of prediction models of TULAC success. This model incorporates 6 variables, which you can obtain easily at the first prenatal visit. This factor included demographic variables as maternal age, ethnicity, pre-pregnancy BMI, variables related to the prior cesarean delivery as a recurrent indication, length of time since cesarean, and variables related to the obstetric history, any prior vaginal delivery, number of prior vaginal deliveries, any vaginal delivery subsequent to cesarean, prior preterm, vaginal deliveries only, and maximal birth weight of a prior child, and variables reflective of pre-existing medical conditions. This is figure of the prediction graphical normogram of the model. You can scan the QR code and reach to the graph. This model, the original model which was introduced in 2007, wasn't presented all ethnicities and races. This was a defect in this model, so they made a model modification of the Group Man's model in 2021. This is the online calculator. We can introduce the data of any women and calculate the VBAC success rate. You can also scan the QR code and reach to the online calculator. This is our summary of recommendation according to VBAC. Prediction models. Group Man prediction model is the most frequently validated tool to predict the probability of success of vaginal birth after cesarean. Since the Group Man prediction model hasn't been validated among certain ethnicities, including the Middle Eastern, the modification version, which excludes race, is appropriate tool to our region. Use of the prediction model is recommended in low resources country, especially because there is a restriction to VBAC practice are significant due to limited resources. The prediction models are globally accessible and awareness of their value, and the availability should be promoted on national and regional basis. Use of the prediction model to aid women counseling should be made along with discussion of benefits and risks of repeat cesarean delivery and vaginal birth. Machine learning-based prediction model may be associated with promising results, but it still needs external validation of the performance. Impact of implementation of 2 lakh prediction model should be prone to internal monitoring and institutional audits. This is our references. Thank you.
Thank you very much for this excellent presentation.